Okay. Good morning, folks, for joining us on this beautiful morning as we enter the fall weather of Iowa. I don't know if that's good or bad, but here we are. Thank y'all for hopping on. Hopefully this is what you're anticipating. This is a discussion on extending birth control cycling in pediatric and adolescent care. We are joined by the wonderful Dr. Michael Colburn. And I promised a very short intro, so I will say Dr. Colburn is a clinical associate professor of adolescent medicine and serves as medical director and pediatric residency director with expertise in adolescent health, medical education, leadership, lots of advocacy skills, and bringing extensive experience in guiding both patient care and physician training. This topic has been requested multiple times by Iowa chapter of AAP membership. So I'm very excited to host this today and to have this recorded for other folks to review when they're able to and ask any questions as we go along. As I mentioned, this will be fairly informal, though Dr. Colburn has been wonderful to curate some slides for us to walk us through some of the history and talk about in-depth discussion of how you go about doing birth control cycling and some of your burning questions. I will have some announcements at the tail end, but we have a ton of content probably to go through, I assume, because this is a complex discussion. So I'm going to hand it over to Dr. Colburn to take it from here.
Thank you for the introduction. I loved it. It was to the point and didn't age me, so thank you. I think, hi everybody. I think what better way to have a talk early in the morning than to have some slides, right? So what I'm going to do is I'm going to talk a little bit about birth control overall, and then I'm going to really kind of narrow down on what's the approach of the most often and common things that we do. This is based on evidence and some expert opinion, but it's also what is in your comfort zone, right? So I just want to preference this, that this is not the only way to do stuff, but this is a way to kind of like approach certain things. And to date myself, let's talk about, birth control management, baby. Let's talk about you and me. All right, cool. I have nothing to disclose. I make no other money. And I'm not going to be talking about anything that's off-label juice. A little bit of basic science, pathophys, right? What is the whole reason that we use birth control? It is to lead to negative feedback of our hypothalamic, pituitary, and ovarian axis to work towards suppression of ovulation, right? If we tell our body, hey, there's levels that seem like we're maybe pregnant, we shouldn't have a litter, then our body kind of goes back and goes into quiet mode, right? And what are the hormones that we most consistently use in this setting, right? It's estrogen and progestin. And those are the surges that happen. Estrogen happens a little bit more in the follicular phase, which kind of helps with cell proliferation of the uterine lining. And then progesterone really creates a nice inhabitable environment for that fertilized egg to implant and turn into the wonderful little babies that we all love, but I actively try to prevent happening for at least a good standard amount of time, right? So we did a little basic science. I like to think of it like this, right? In the grand scheme of things, the LH surges and just smacks that follicle to like have that egg just shoot out, and then that progestin that's in that corpus luteum is staying behind. And once that kind of runs its course, that's when we have our bleed. Right? So that's why birth control pills are set up in the way that they are, where you have 3 weeks of active hormones with estrogen and progestin, and then 1 week of placebo. Do we have to do it that way? Not necessarily, right? And most people appreciate if you have that conversation with them, so we'll get to that. All right, what kind of things to talk about? And I have a feeling that the audience in the room knows this better than I do from time to time. Being a male provider, what did I just do? In a sea of men, I have a tendency to sometimes not have as many females, especially during the summer season. So menarche on average, this is a really hard number to come up with. The data is always kind of like all over the place. We put 12, we put for people that are maybe not Caucasian, maybe more of 11, breast development at 6 years of age could be normal and is not usually problematic. Pubic hair at 6 years of age may be something to look at. So, in the grand scheme of things, menarche or forced menstrual period is just a running target. But if this was ever a test question, 12 still seems to be the average age of onset, especially within the Caucasian population. If your clinic asks last menstrual period, I love when clinics do that. I think it's just a good way. Use it as a vital sign, and it helps you have conversations with them. Cycle regularity, right? So that's kind of the period with nothing in between. When we first start having our periods, they are about up to 80% anovulatory. So this can be just leading to the irregularity that we see. And it can take up to 5 to 7 years for people to have like predictable, consistent, right? We really see the vast majority of people within 2 to 3 years kind of fall within that pattern, but there's no necessarily any worry about it and give them time to mature. Cycle frequency, the norm is anywhere between 3 weeks to 40 days. Duration is 2 to 8. But in the grand scheme of things, you're looking more for like too much bleeding, right? Flow, I don't know how many people bring out diagrams or draw menstrual pads or tampons to really figure out saturation. Changing habits can be across the board for several people. When you look at trying to figure out 20 to 80 milliliters or 80 milliliters of blood loss during a cycle is too heavy, it gets a little bit hard. But the best ways to kind of look at heavy flow indicators is just looking at their nighttime routine. When they go through a period of time, that was not a pun intended, where they're supposed to not really be doing anything, do they have to do other interventions to prevent bleeding onto bedclothes and bedding, or do they show any signs of anemia? Those are kind of the ways to go about thinking about that. Dysmenorrhea, fundamentally, it comes down to, does it prevent them from being productive in their setting? Are they missing school or work? Right? We can talk about things like NSAIDs and scheduled NSAIDs, and we can use hormonal regulation, not necessarily make dysmenorrhea fade away, but maybe make it less often. And abnormal bleeding is any deviation of what we've just talked about up above, but remember, abnormal uterine bleeding is very common and secondary to anovulatory cycles within those first 2 to 3 years after people begin having their periods. So why does this matter? I don't think I need to tell you that, but adolescents, you are their like trusted guide for sexual health education. I know sometimes it doesn't seem like that. And I know sometimes that it seems like whatever the new thing in social media is. But when you hear about it and they bring up questions to you, right? You are this person that has been able to create this relationship that you're another safe adult that they can go to for information, right? So I always prompt us to kind of be that person for these young, growing, almost adult consumers of healthcare to be impactful, right? And there's a lot of barriers to kind of prevent equitable contraception care. And our goal in the state of Iowa is to make sure that everybody receives the care that everybody deserves. So looking at ways to overcome some of those barriers, I'll talk about it in a little bit. AAP continues to support minor self-consent. It's legal and confidential contraception care. It's very complex with different states having different legal kind of like landscape. However, Iowa is still allows full consent for contraceptive care within our state with minors. And then HIPAA permits confidentiality, but let's be real, systems constantly breach confidentiality with our electronic health records, our proxy access, which is really good, but then doesn't give them anything. So what parent wouldn't be tempted just to have full access so they can actually refill people's diabetes medication, right? And then in explanation of benefits can get a little wonky sometimes, and patient portals can be tricky. So just kind of things that we spend day and day in working with kids and trying to understand this and create a good spot so that we can decrease things like unintended pregnancies. What we should really be familiar with is you got long-term prescriptions and just in time, right? So long-term are your LARCs or your long-acting reversible contraception. Mirena, which is the progestin IUD, is FDA approved for up to 8 years. So it's kind of like set it and forget it, right? Nexplanon, if they want the little bar in their arm, if they're well informed that they'll likely have irregular bleeding, sweet. Otherwise, I kind of hate it with how irregular the bleeding is. Prescriptions, these are things that they're going to do on a regular basis, including the progestin-only injection, which is Depo-Provera, and all of our awesome combined estrogen and progestin options, rings, patches, and pills. There's also a progestin-only pill called the mini pill, and it's available over the counter. Just in time, think of that as anything that you're like, okay, let's do this, which is going to be barrier protection as well as emergency contraception. Bedsider.org is a really good website. It's written in language for adolescents and young adults. It is vetted and it has medical representation and guidance, and it really kind of gives them the pros and kind of the less pros or cons of all birth control options for them. It gives them a wider range of options for them to kind of consider. Once again, your LARCs are most effective with typical use rates. That means how humans use it. Thank you. Is going to be approximately 0.1%. The Nexplanon, or the rod that goes in our arm, the implantable rod, has a little more effective typical use rates just because our body can't expel it, unlike the IUD that can happen sometimes. Copper IUDs do not lead to menstrual suppression, and through the mechanism that they work, has a tendency to thicken endometrial linings or uterine linings and can cause heavier blood loss. So knowing exactly, besides birth control, what other goals your patient has is super helpful. The Depo-Provera injection at typical use is approximately 4%, right, of risk of pregnancy, or failure rates, I should say. And then pills, patches, rings all kind of get lumped together because you think that maybe a ring, which is once a month, or a patch that's once a week, would be better, but it is sometimes harder to create those less frequent habits. So lumping all those short, intermediate changes that are really reliant on patient adherence into that 7% failure rate is kind of where we go. And then condoms are really good. If you do perfect use, you're going to get in your high 90s. But failure rates are high. Why? Because they don't use it, or they don't think the things that are coming out of their body have sperm in it right away, right? So it's typical use means it includes people that say they're using it, but they don't use it. So that's why it gets such a bad rap. I think nobody that's in adolescence is going to get fitted for a cervical cap, diaphragms. They're not anything that they necessarily need to explore. I don't talk about things like spermicide, except making sure that it is appropriate with things like condoms, right? And it is good for them to be empowered and make decisions and have abstinence as their choice. And that doesn't mean that you can't talk about these other options that are available. The birth control shot has this additional confidentiality element too, because it gets woven within your visit. And I think a lot of us can come up with reasons why somebody needs to see us in 3 months, to see if they're working on a healthy lifestyle, to see how their mental health is going. It's the start of the school year. And that shot doesn't get called out really easily within the explanation of benefits. So if there's elements of big worry about, I want to pick up a birth control prescription, but I'm worried that my parents are going to know, that could be one way. Plus, it's a great bridge to kind of lead for that 12 weeks to get them someplace that might be placing LARCs for you. So that's kind of a little bit about the effective comparisons. I put this slide on because, like, just talking about the adverse effects of hormonal contraception, I feel like it overwhelms us so much, because I think we all want to do so right by our patients, and we want to make sure that they have the best information. And this is more of a reference for you, but to master this, it just takes time and practice and things like this. But I think instead, looking and going into what more likely you're going to be managing more often than not is an estrogen containing compound, right? And an estrogen containing compound like a birth control pill, those are kind of good things to evaluate for absolute contraindications. The US and the CDC, the birth control contraception app is super helpful. It will allow you to look by medical diagnoses. So if you're like, oh, I have that person that has sickle cell, that's not anything I need to worry about, right? You can just go right there and see what is or is not contraindications. Migraines with aura is based on past data with high dose estrogen. I think it's getting closer to being put as a caution than a contraindication, but within the most recent update, it's still listed as a contraindication. Teenagers love to use words that are highly incorporated into society and pop culture, and headaches are migraines, but they might not actually be migraine. And fundamentally, what I found that has been really helpful for aura is really having that timeline. Before your head hurts, is there something that happens that will tell you within the next 30 minutes you are going to have your headache, your migraine? And when they say stuff then like, oh yeah, my vision gets a little bit weird, and then I know I need to go into a dark place, and that's when I take my ibuprofen, and then within like 20 minutes my head starts hurting, and if I don't do all that it hurts even more. That's an aura, right? It's an early detection warning sign. But asking if they have visual disturbances or things like that with the migraine, that happens. So really kind of being like, before the pain happens, is there a predictive kind of warning sign? Those kids should not be on an estrogen containing product. People that have personal clotting history or a strong genetic first degree relative with clotting risk are to be considered probably not the best candidates at all, and exploring progestin only options. Meta-analysis that came out probably within the past like 7 to 8 years, maybe it was more like 8 years, looked at all birth control, right? All birth control increases our clot risk. But in the grand scheme of things, I have a better slide to talk about that. So I'll get off my high horse for a second. So if you are like, I have this person, I explored options with them, and I follow kind of the standard recommendation, which is marketing persuasive technique, which you should always start with the most effective, which would be your LARCs, and end on the ones that have the highest failure and typical rates, which is going to be condoms, and then right before that, estrogen containing products. They will still pick the good option that's for them. But when you start with the LARCs, it shows that you have confidence in them and attention spans are limited. So I think those are the two things that go in the continued recommendation to talk in an effective order when you're discussing these. When somebody comes and they're like, a birth control pill is a good fit for me, awesome, that's great. And it's good to have a blood pressure. Estrogen can lead to increased blood pressure, but you don't need to do anything else than that, right? You don't necessarily need to be getting a pregnancy test if you have a last menstrual period. You do not need to do a pelvic exam, right? You don't have to do any kind of workup. If they're having unprotected sex, sexual health testing is warranted in that situation and should do it annually based on the CDC's recommendations for gonorrhea and chlamydia. But like, a lot of times people are a little bit in that headspace that if you create a space, they'll talk to you before they need it. And that's the best time for us to be starting birth control. So with all that in place, right, we need to expand access, and we've already done that a lot, right? To help with cost and transportation limitations and confidentiality, right? We have telehealth options. There's online mobile prescribing that is like licensed in several states that people can go to. Pharmacists can prescribe the estrogen containing products, so things that are self-administered like pills and patches and rings, right? So, and that includes the state of Iowa. And there's over-the-counter options, right? The mini pill. Which is effective when you take it perfectly and it's finicky. So this one's kind of the ones that you need to take it within an hour or so of when it's kind of needing to be taken. Otherwise, your effective rate can drop to like 1 in 10 failure, right? Which isn't ideal. So, okay, so you have this person, you've created a space. You don't want them to go get the over-the-counter progestin only because there's better options for them. And you're like, are they having sex? Like, oh, are they pregnant? Like, if I do something today, is that going to hurt a fetus? Like, what do I need to know, right? So when you look at how can you be reasonably certain someone is not pregnant, right? If the patients have no signs of pregnancy, aka no morning nausea, things like that. And two, it's been like 7 days or less after the start of normal menses. So it has only been like a week since they had their period, or they haven't had intercourse since their last normal menses, or they're using their form of birth control consistently, right? Nobody's going to fault you for getting a urine pregnancy. And if it's not a confidential need, it's a good standard of care. The urine pregnancy is just sometimes how to work if there's like a confidential need. Being able to do a point of care urine pregnancy tests within your clinic so they don't have to go to a lab is a helpful way that when the parents are in the lobby, you can kind of have these discussions and have this testing done and go from there. How long is backup method needed? The trick is always, right, because it's STI protection. None of this other stuff does anything with STI. That's the adolescent medicine joke, right? But in the grand scheme of things, it's 5 to 7 days once you start something, depending on what type. So if you just consistently say you need to be on it for a week or use condoms for a week after starting for your people that are in monogamous relationships, or you feel like they're lower risk for STIs, then that's kind of a good way to cover everything under the sun for you. And then when should you start? I'm a fan of starting now, right? Because in the grand scheme of things, same day start's the best thing for them. The Sunday start is arbitrary man science, right? Like if you take your placebo day one on Sunday, then your womanly time will happen during the week when the male is at work. And then the weekend, your bleeding should be done when you have to do your wifely duties. That's all bullshit, right? Like, some guy came up with that crap about Sunday. So in the grand scheme of things, have them start as soon as they pick it up, because then that shrinks that interval to when they might get pregnant down the road. So there's a lot of options, right? You're like, Colburn is like, if they're going to do a pill, a combined estrogen and progesterone pill is the best option. And where do I start? You guys have been practicing. You probably have your go-tos. When I'm teaching people kind of like who are like blank slates and they're like, I don't know what to do, I'm like, well, what do you want it to do? So if all these pills can lead to good birth control when taken appropriately, then the next option is I want to try to prevent some of the side effects from happening, or I also want to have some benefit, right? People use birth control pills and notice the benefits from acne and how their hair feels. That's going to be kind of that, what we would call a mid-range estrogen dose, right? That 20 to 35 milligrams or micrograms of estrogen is going to lead to that increased sex binding hormone globulins that's going to block up their androgens and help with acne and how their hair feels and hirsutism elements, right? So I would say if there's no contraindication to estrogen, start there. So then it's like, well, what progestin to pick? And progestin, kind of like our cephalosporins, have different generations as they come. And they have different effects. And we look at kind of like the negative effect, which is going to be an androgenic activity. So your norgestrel and your levo, that has a higher element of that. Northindrone is kind of in the middle, and that's your mini pill element. But the little ones, the one that has less activity, is dogestrel and norgestimate. And when you look at norgestimate, that might be the one that you're actually maybe doing. And I apologize for blowing this up and it looking like crap, but I made this slide this morning. This right here, the norgestimate, is also called Sprintec. It's also called orthocycline. It's also an orthotricycline. But sometimes it's really good to just do a monophasic, especially if you're thinking that this patient or all patients should have the opportunity to go to extended cycling. What monophasic means is it's just the same progestin each day. What a triphasic, don't use biphasics, it's not good evidence. What a triphasic means is it's an increasing amount of progestin from week 1 to 2 to 3. So if you go all the way back to that first slide, how your progestin in the last 2 weeks were kind of like creeping up before your period, that's what a triphasic's trying to do. Now, that makes sense if you have a week 1, week 2, week 3, and then a week 4 bleed. But I don't see that it makes any sense to tease your uterine lining like that if I'm not going to let you have a bleed for a while, and we do things like extended or continuous cycling. So take out the variables, just focus on one. It's easier to know what the side effect might be from if you don't have this varying dose of progestin. And a lot of your patients will opt into extended or continuous cycling. Dospirenone, that is your spironolactone kind of derivative, right? So it has actually anti-androgenic effects, just like spironolactone does. It goes and kind of acts as a partial blockade to things like testosterone, or like our androgens, I should say. So in the grand scheme of things, that might be really good. People use things like spironolactone for like acne management, right? It got a bad rap about 10 to 15 years ago because their study came out and it said that that had an increased risk more than the combined pills alone. So then people kind of stopped using it. But like I said, that meta-analysis came out and it said even an IUD causes clot risk. And in the grand scheme of things, it's way less than being pregnant. So I use dospirenone if my norgestimate is causing me issues with my patients, or they say bloating, 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 bloating. It is going to be a potassium sparing diuretic. So periodically I may consider checking a BMP just to see what their potassium is at a baseline. And then maybe after a handful of months of decent use, and then call it good. The likelihood of them having too high of a potassium is close to nothing on the low dose of this medication compared to high dosing of spironolactone. So what's your prescribing practice? They don't have aura. Perfect. You went through that. You're like, I'm going to use a newer generation progestin. I'm going to try orthocycline. It has a longer half-life and it has less of a metabolic effect. And it's a combined, so that that estrogen on there means they don't have to take it as close to when they usually take their pill. So if they take it within 24 hours, they'll probably be good. But if they confuse their body too much, then that might not be good. And like I said, your Yasmin is a really good option if your other ones are failing, or if you're interested in trying to treat bloat. Here's that slide finally about clotting risk, right? So when nobody takes any additional hormones, it's 2 to 5 per 10,000. When people are taking like our earlier progestins, so those were those more androgenic effects, it was 6 to 8. With dospirenone, it was 10, and the study was big, so it's statistically significant. The patch has a little bit higher estrogen component in it, or gets into our system, so that's why that is also a 10. The NuvaRing is 8 to 12. That is the inserted ring. And then all that pales to when somebody is like pregnant or gives birth, right? We don't stop anybody from having a second child. If you take all of your time on a combined oral contraception for your whole lifetime, that area under the curve, thanks, Annie, is less than just your second pregnancy, right? Give them a full year. That's the standard practice. Don't be a barrier for them. The likelihood is if their blood pressure looks good, it's going to still look good. And then when they come back, finally check that blood pressure to make sure they're fine. The main reason to have them come back in 3 months, blood pressure, whatever, it's really to just be like, is it working for you? And if it is, then cool, you've decreased pregnancy risk. And if it's not working for them, then you explore something. If you let them go a whole year, they don't like it, they might just stop, right? Depending on what your MyChart practices is or communication styles. So how to be an inclusive care provider, right? So when you look at kind of like the language around certain stuff that we might be talking about, things can be sometimes dysphoric. Periods are notoriously linked to femininity and female. So sometimes using just like talking about bleed is a way to kind of de-gender that kind of experience, right? And when you talk about things like an intrauterine device, you can talk about how a provider uses something that's called a speculum, because they probably have no clue what you're talking about, to look in the potential space that is your genitals so they can find your cervix, right? So sometimes that word vagina can be a little dysphoric as well, depending on like how much these languages affect them. It is always good practice to be like, when I talk to you, I want to use anatomical language unless certain words are problematic. If certain words are problematic for you, If you can tell me that now or just nod, then I'll avoid the words that I believe are problematic. But some kids have no issues with vagina. And if society was just better and males could have vaginas and males also have boobs because I have man breasts right now, right? Like, then things would be a better place. Hormonal treatments, testosterone, even though it can lead to menstrual suppression, is not a guaranteed anovulatory predictor. So people can still get pregnant on it, and adherence with testosterone can wane when people are getting the effects from testosterone that they desire. Because your voice dropping doesn't go away if your testosterone stops. And it's really nice to think about, like, within your scope of practice, things that could be affirming. That's things that you would just do for a cis woman, right? And that's a little bit where things like da 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 extended cycling comes in. But when your person comes back and they're like, huh, I got some side effects, these are kind of like the main thing. If you pick something like orthocycline, that's that mid-range 35 micrograms of estrogen, almost every side effect that they're going to say they have is because of the estrogen. So then you pick an option that has a lower estrogen. When they say stuff like my placebo week happened and things were kind of okay, but then I started my next pill pack and it was blah, that is just that estrogen type element. The reason why, once again, estrogen is good to start at that level is it will significantly help decrease breakthrough bleeding, as well as help with the effects of the beneficial effects of birth control besides pregnancy prevention, such as acne and hair. But if they're talking about things like bloating, breast tenderness, headaches, and nausea, just drop it. If they say their dysmenorrhea is still present, but they like other things about it, then your goal is extended cycling to push out how far or how often they have periods. I think I have one more slide, and I was going to flip it back to just talking to you face to face a little bit about extended cycling, and then kind of go from there for questions. There was a really good prompt during the chat, which I was like, ooh, you guys are ahead of the game. But when you think about an IUD, I'm a cis male. I hate when they're like, it's better than being pregnant, right? Yeah, sure, whatever. But like giving them information to kind of actually figure things out. I think that the procedure across the board is relatively stable, depending on if you use one of the smaller rods. Long-term benefits from one of the smaller IUD rods is kind of like mixed data. So it might be better to potentially lean into Mirena to have the longer coverage than the other IUDs potentially, because most of the discomfort is associated with the procedure. This bedsider.org, once again, the website I plugged in the beginning, has a really good video. It's about 4 minutes, and it gives a breadth of people's experiences having the IUD placed. So sometimes it's good to direct your patients here to hear from people that have actually had it placed. This might be one of those times that, depending on your comfort level, you could share things about your own choices in birth control and kind of how you felt. This is where I welcome parents to share information or caregivers to share information, because fundamentally, the more the kid is made aware of what might happen and they make the decision to go through it, the better they are going to feel about their decision, and the more likely they're going to keep their decision than if they're kind of things are sugar coated or summed up that, well, you don't want to get pregnant because delivering is way worse, right? So that's just my little plug. Cool. All right. I think that's it. So who in here, maybe by a show of hands, has like does extended cycling all the time or talks about it with their like patients? Amy. Cool. This is why I feel like you're here today. So let's get down to it. In the grand scheme of things, extended cycling is super easy. All extended cycling says is you skip the placebo week for a period of time. Continuous cycling is you skip the placebo week all the time. All right. So those are those two languages. When I do extended cycling, I never start with extended cycling. I always start with just taking the pills as prescribed, because I do same day starts. It's probably in the middle of your cycle. You're going to have random spotting for the first 3 weeks, which I tell them is going to happen. Then you're going to have a period that's going to reset you, but you're starting now because you're like, birth control now is good. So we're going to work towards your goal. And then the next pill pack, you're going to tell me how you like, right? Because you shouldn't have any spotting. How are your symptoms? How's your bleeding, right? How's your dysmenorrhea? How's the heaviness? How's all that? And if that's good, I'm hoping to see you back during your third pill pack to make sure your blood pressure is still fine and that you're going to tell me everything's good. If things are not good, you should be messaging me because we could pivot while we're doing it, right? On that follow-up is usually when I start talking to them. I hinted that they can have less periods, but the first conversation is so overwhelming with somebody that's never taken pills before that adding all that right off the bat just kind of makes eyes go really big. So then the second is when I talk about extended cycling. I ask them, do you want to have less periods? Sometimes people want to have periods because it tells them that they're not pregnant. I tell them if you take your birth control pill every day, that also tells you that you're not pregnant. So it's okay. They sometimes say it's detoxifying. I say no. They sometimes say if I don't have a period, I'm at risk for cancer. I'm like, how you're taking your birth control pill, if you take it extended or continuous, your risk for cancer doesn't change and your protection for cancer is still there. So that's all cool. But if they want to do it, then I just tell them do 12 weeks and 13 week is when they have their period because they're testing their body to see how far it can go. So they have 4 pill packs because you wrote for the magic number of 112 with 4 refills. You only needed 3, but you're going to give them that little bit extra cushion. And then they skip placebo week in pack 1, 2, 3, and lucky week 13 is when they have their bleed. If their body can get that far, then you could be like, you could push it farther. If their body can't get that far, then you still switch to continuous in the grand scheme of things. So what continuous is you take your active pill every day until you start having spotting, or you want to have a bleed. Maybe there's some event coming up, or it's moments before a swim meet or something like that. You're like, let's just reset my lining and go from there. When spotting happens or when you want to have a bleed, you just take 3 days of your placebo week, your bleed happens, then you go straight back to your active pills. Easy peasy. So the vast majority of my patients don't want to have periods, including my gender expansive individuals. And when they're not on testosterone and estrogen is not dysphoric to them, even though estrogen doesn't highly feminize, because if a birth control pill made breasts larger, I think more people would be on it, right? That's usually the route I go because having just that little bit of estrogen on board significantly helps decrease your breakthrough bleeding. So I talk too much. I apologize, but I'm available for questions for anybody that's still around and can go from there. And I'm available to chat at any other time too. So, ta-da!
Yay! I have a question. I have like a lot of questions actually, but I'll try to keep it tame. First of all, I just wanted to tell you my experience. I see a lot of young adolescents who have special needs. And so just wanted to mention that I always try to address their bleeds and how to best handle that with the families. But I'm sure you would have a lot of thoughts about that. I did want to say though that I ended up giving some type of an estrogen controlling medicine. I think they were on continuous cycling or continuous pills, and they did get a DVT because they're in a wheelchair.
Yeah.
And so I think that really is going to make me hesitate the next time I have someone who is not very mobile to do that. So that wasn't on my radar because it's not on the list of contraindications necessarily, like in my head of like if you don't ever move your legs, like you might get a clot in them. So I just wanted to throw that out there. And I think that we ended up trying to think if I sent her for an IUD or if I like got her on the mini pill. I think she might be on the mini pill. Would you do mini pill in her?
Oh, you could do mini pill and then just let the parents know if they're still having issues with bleeding. Mini pill works a little bit differently. It doesn't always lead to menstrual suppression. Sometimes it's
Hmm.
just mucus plugging and sperm motility issues. So
Okay.
with that, if they continue to have bleeding on the mini pill, a sedated IUD, right?
Okay.
Like just give that person the comfort, the twilight zone, and just
Yeah.
let them have an IUD because 80% of people within the first 12 months will become amenorrheic, right? So
Right.
like if you're really looking, and I have this with my gender diverse individuals too, if you really are looking to what are the best ways to make your bleeding go away through these options, it is always going to be the IUD, but that still is 1 in 5 people still have issues. So
Hmm.
mini pill, if it's working for them, great, because you have
Hmm.
any clot risk then. It's substantially less
Hmm.
than the estrogen. But I might work with your gynecology represent or team to see if they can do a conscious sedation
Yeah,
IUD
we have
placement.
like in Des Moines, we have three of the greatest OBGYNs in the state. So I send everybody to Broad Lawns. Um, don't tell Unity Point I said that, question mark. Um, I also I discuss menstruation with all of my uterus folks, and the younger kids who are upset with their periods or don't like their periods or whatever aren't very good at compliance with pills and aren't ready yet mental space wise for something like a lark. They think that's overwhelming. So I found that a lot of the 12-year-olds and 13-year-olds really like the patch because once a week is something they can do and they can have their mom remind them. And it's like a thing that we talk about a lot. Um, do you like I have a person right now who's having trouble with still a lot of breakthrough and stuff on their patch. And she has Medicaid. And so I'm like, there's Xulane, which is the one that gets paid for by Iowa Medicaid. And then there's two other ones, Twyla or something, which is that's a cute name. And then another one that's cute, which require prior auths, which I'm not very good at and sometimes don't make happen. But how can I get this patch to work better for this girl? Am I doing something wrong with the patch or like, is Xulane not the best choice for this
No,
girl? Like,
the patches are all relatively interchangeable. And the question I have for you is the patch, because it's going through our body tissue, right? That's the one that's going to be most linked to obesity as deterrent from using, not because it's going to increase hunger cues like your depot injection, but
mhm,
you have a weight threshold of it's not that high. I always want to say like it's 97 kilos sounds high, but I would always have to look it up. So I would tell
mhm,
you that if she flags into the overweight category, it might not be as effective, and that's why you're having breakthrough bleeding for her.
mhm.
If she's weight neutral, then in that scheme of things, sometimes that continuous or not continuous because it's good to take your patch off because of that higher estrogen dose. That's what I'm supposed to recommend. Um,
Mhm.
Explore another option if I
Okay.
had somebody that was trapped and really loved their option, so maybe Depo, maybe um, Nexplanon, or maybe an IUD. If someone's trapped and they're like, I really want this, but my bleeding sucks or it's unpredictable, that person has motivation to potentially try something. So in that person, I would add a combined oral estrogen progesterone product to regulate their cycles that there is your double coverage, but it's not going to substantially increase any risk. The estrogen part is going to help regulate and make their cycles predictable. And what I found is when they're doing this, especially with Depo, they learn that they can take a pill every day and they don't need Depo anymore. So then they just transition to the pill alone. Your Depo, remember, it has some bone formation impairment, right? So calcium deposits, and you need to have good weight bearing exercise and good calcium intake, which sometimes our teenagers don't. You're supposed to be on it for 2 years and then get then you're supposed to get
A
a
DEXA.
DEXA. And then if your DEXA doesn't look good, you're not supposed to do it anymore, right? So I don't do that. because if this is the only option that they're going to do, I'm going to let them still have that option, and everybody should have good forms of calcium and weight bearing activity. So I don't find that the DEX is super helpful. But once again, if it's a Mocha Peds question, that might be the answer for you to do there. But it's always important to talk about advancing their care with each assessment of their birth control. Is there a way to get them a more effective one? So Amy, for her, it might be like, right now, this one doesn't seem like it's a good fit for you. We could try a pill because you've been doing so well with your patch, right? So maybe we try a pill. It doesn't have to be absorbed through your body in this way. We could see how that helps for you and just float that out there and see what they say.
Okay, I think that your advice also about um, doing a full pack at first to kind of like reset their period and then can do the continuous cycling will also help because I haven't really been doing that. But the biggest piece of advice today that I'm taking home is your advice. So a lot of my older teens who are sexually active like the idea of getting a Nexplanon. I'm with you. I don't like the breakthrough bleeds, but Bingaman says that you can also put them on a pill in addition to that for a couple of months to get things tamed down a little bit and they tolerate it better, which that was really important knowledge for me. But to say it takes time because I don't put in Nexplanon. So from the time they leave my office to the time they get their Nexplanon is the time in which they get pregnant. So I really love the idea of let's do a depot shot today, and then we will get you in to get your Nexplanon. Because in general, my families don't like the depot for the side effect profile of gaining weight and the acne and the hair and all of that other fun stuff. They aren't even thinking about their bones. But I do like it as a bridge to getting them where they need safely. I have had literally in the past 2 weeks, I've had 4 19-year-olds bring their new babies to me, and I really would like to slow that trend. So that's going to be that's going to be a big helpful tip for me. And thank you so much for doing this today. This is amazing. And I wish I could bring you to DMU to talk to the students there directly because they would love this too.
I'm up for a road trip, so we can set something up. That'd be easy. Yeah, no, I think it's weight gain, weight gain, weight gain, right? So in the grand scheme of things, being like this is one shot at depot to honor your I don't want to get pregnant while we wait for this other thing, that is not linked to substantial weight gain. One shot of depot. It is depot as a choice for a while. So usually kind of the problematic side effects that people notice is going to be with at least a couple shots of depot and then changes to their eating patterns and their hair consistency and things like that. So it's usually a one cell is okay. Liza asked a question about kind of like, do I avoid depot in younger kids? What I'll do, so when I was in Cincinnati, I got a lot of people who had their first period, and then mom brought them in and was like, I'm not going to be a grandma yet, put her on. But like this kid wasn't right. This was mom's paranoia, and the kid wasn't a sexualized being. So a lot of times I really try to push like, what is the goal for starting right now? Are they at risk for this right now? Maybe this is not the best option for them, right? And with things like depot, I don't necessarily hold off, but I do hold off on birth control because the parent is driving the conversation and not the kid, especially in people that are just menarchal. A lot of times when they looked at the data, if a kid has an additional 4.5 centimeters of height that can happen once they have their first menstrual period, that when you do things like estrogen containing products, it can kind of dampen that additional gain. 4.5 centimeters, most people are like, that's not a big deal. But I think it just brings into the grand scheme of things is all the stuff we do has side effects, right? So we're always looking for what's the balance of when the pros outweigh, and being on depot for mom's sanity in a 10-year-old in our patient population is like not appropriate. So I do hold off. Liza, if that's kind of, does that answer the question? Cool.
Do you have similar thoughts? I'm looking at Bola's question for bone health management for special needs kids as well in relation to depot.
especially when they are not able to do their own weight bearing activities, right? So, like when Amy brought up her patient that was wheelchair bound, right? So, if you special needs, nutritional difficulties, no weight bearing activity, like Depo is just a setup to make that kid probably not transportable eventually, right? Because they're going to be hungry and they're not going to be able to communicate as well. And there's like elements of frustration with that. So, food access is going to be there for them as comfort, and then that's hard, right? So I would say any kid with special needs would highly benefit from a caring, compassionate gynecologist who is not barbaric, who has good pain management skills and sedation, and then get that kid an IUD, because in the grand scheme of things, it's weight neutral. It's going to work locally. It's going to lead to the most success with bleeding. So that's kind of where I always go. And I push the people that I work with, this is sedation, right? And sedation has a risk, but a kid that is intellectual disability and explaining to them a speculum exam, it's just not going to be functioning well in that situation. So some conscious sedation is the best way to go. So that's how I usually go with that, Bola. Mm-mm-mm.
And then we had another question in here asking about over-the-counter pills for girls that want to be on birth control, but menopausal moms are saying it can decrease libido and cause hormonal imbalances. Kind of how to approach that.
So the adolescent libido is powerful. And the thing that I'm thinking about right at this moment is mom's medications, also including an SSRI, right? Because I think this has some inherent parent anxiety component that's to it. And there are things that substantially decrease libido more that we don't even hesitate to think about prescribing, right? Like an SSRI when it's appropriate. So an estrogen or a combined birth control, libido, it's gonna be fine. Amy already hit on the biggest risk. It's going to be that DVT, right? Everything else they're going to notice. The DVT is going to linger for a bit because nobody really pays attention to unilateral calf pain. They're just like, I must have did something, right? So when parents are really worried about the options, the best way that I find to build buy-in with anybody is to ask them, like, what did they experience themselves? Give them that data that I have that is from our studies, right? And then ask them also, well, what has worked? And when they pick something that's like way over here, right? And that's in the land of mental health, it's like step 7. Then I'll explain that everybody is uniquely different. Your daughter is only 50% of your genes at, depending on relationship. And in that situation, this other option might be better for her, but we're going to have close monitoring. We're going to be watching for that stuff. You've created a space that we can talk about sex drive. So thank you for doing that, because sometimes people might not feel comfortable talking about sex drive. But it's good to know all the side effects, including decreased horniness. So let me know if something like this is happening with your pill, and we can try a different pill or we can try a different option. So I think it's acknowledging it, validating it, using the data to rebuke certain things, but also figuring out what they think might be a good option. And if it fits within the scope of things, then I usually lean into it.